Hi, my name is Sukriti Kc, and I'm a PhD candidate at the Department of Primary Care Public Health at Imperial College London. And I'm here to talk about my project, which is an evaluation of the adoption and use of the NHS app in England using a mixed method approach. I would like to start by thanking the conference organizers for this opportunity to present at the HSR UK conference this year. And I would also like to thank my supervisors, as well as our wider project team, for the contribution to this research that I'm presenting. This is a joint collaborative project between our team at Imperial College London and the University of Oxford. So to start with a bit of background to the project, the NHS app was launched in January of 2019 as a digital front door to England's national healthcare services. It is a platform that can be accessed through mobile phones or web browsers to use a number of functions such as appointment booking, ordering repeat prescriptions, symptom check, etc., which were introduced when the app was first released. Over time, additional features have also been introduced through the app, such as the COVID Pass feature, which was launched around May 2021 during peak COVID outbreak, which allowed users to check as well as to verify the COVID-19 vaccination status. More recently, additional features such as video consultation, managing hospital waiting time is also available through the app. So it is quite exciting that such a technology is now available at a population level in England, because literature tells us that they can be cost-effective and scalable solution with the potential to reach a large amount of people within a very short amount of time. However, there are growing concerns that such technologies, when introduced in health, may contribute to, or they may even worsen the existing health divides by marginalizing the disadvantaged group. They may also be creating an entirely new divide on its own called a digital divide, where those at the risk of social exclusion are also then excluded from these digital technologies. Therefore, there is a need and this real emphasis on healthcare technologies, not only for them to be safe, reliable, and secure, but they also have to be equitable, or they have to be able to influence equality of outcomes for all. Now, with the NHS app being relatively new, we do not yet fully understand its impact on healthcare equity or how the app is currently being used by the general public. So to answer these questions, we designed our study, which aimed to evaluate the patterns of NHS app uptake and adoption among different population groups in England. And in doing so, we really hope to answer three key questions. First of all, how was the app being used and whether COVID-19 impacted this? Second, did the app uptake vary between different population groups? And third, what were the experiences of patients as well as practices in using the app? So I will now go on to our methods, but then again, break them according to our research questions for further clarity. So our research methods included both quantitative as well as qualitative approaches. So to break this down according to our research questions, the first question, how was the app being used? To answer this, we designed an interrupted time series analysis using data from the NHS app dashboard ranging from January 2019 to May 2021. So the interrupted time series allows us to understand changes over time and in relation to key time points. So for our study, we added an interruption to the 1st of April 2020. So this was the time around the first lockdown when it was introduced in England. So we introduced this interruption to see whether there was any effect on app use before and after the lockdown rules. The app data that we used included aggregate monthly counts of various functions used, such as registrations, the number of download, prescriptions ordered, etc. So this allowed us to see how was the app being used just over a 2-year time period. So moving on to the second question, did the app uptake vary between different population groups? To answer this question, we designed a regression analysis. So the regression analysis looked at the differences in app registration rates by GP level sociodemographic variables across categories of age, sex, ethnicity, long-term healthcare needs, and the GP practice size. So the data that we used for this analysis was available from a number of publicly available databases, such as NHS Digital, Fingertips Public Health Profile, GP patient survey results, etc. We also supplemented our quantitative findings with qualitative approaches to answer our third question. what were the experiences of patients and practices in using the app. For this, we conducted observations undertaken across 4 GP surgeries in England. We also carried out approximately 57 interviews and about 4 focus groups with 83 participants. So our participants were mainly patients, but we also involved managers, clinical staff, and wider stakeholders for a much broader perspective into the use of the app. And we included a mixture of male and female, people with varying health conditions, various ethnic groups, as well as those from urban as well as rural practices. And the data that we obtained from our qualitative methods was analyzed thematically and informed by the NAS framework. So now to move on to our results, again, broken down according to our research questions. What did we find in terms of the app use? What we saw was there was a strong interest in the NHS app with approximately 8.5 million downloads and 4.5 million registrations at the end of our study period in May 2021. However, if we look at figure 1 on the left-hand side screen, what we can see is that these numbers clearly relate to COVID-19 episode. So just after the first lockdown was introduced, we can see that the numbers are peaking around that time, and they rise more significantly after the COVID pass was released in May 2021. So what this tells us is, while the initial public reaction to the app has been great, we can see that COVID-19 was a huge driver for this change. To break this down further in terms of app use and inequalities or equalities in app use, we conducted a regression analysis, and the results showed that there were some interesting patterns when it came to how different groups were using the app. So for our regression, we compared practices in the lowest quartile to the highest quartile for each of the socio-demographic variables. So looking at deprivation, what we found was practices in the most deprived areas had a 25% lower app registration rate compared to the least deprived practices. Also, the largest size practices had a 44% higher app registration rate than the smallest size practices. Registration was also 36% higher in GP practices with the most white patients, and it was 23% higher in practices with the highest number of young adults, or those ranging from 15 to 34-year-old. In contrast, we found that app registration was 13% lower in practices with the highest number of male, and 2% lower in those with the highest number of people with long-term healthcare needs. So to summarize these findings from the regression table, we found that practices with higher rates of app registrations were from less deprived areas, and they had a larger practice size. The GP registered population for these practices were younger, and they were less ethnically diverse. We also saw that these GP practices had a lower percentage of registered male and people with long-term healthcare needs. So clearly, there is an inequality trend that we can see in terms of app registration. So to supplement this with our qualitative findings, I have listed some key headlines which emerged from our conversations with patients and practices. So to draw this out further, regarding the technology itself, we saw that some of the app functionalities were considered useful, as well as the app interface itself, which did connect well to the existing digital services. For example, through the NHS app itself, patients could access symptom check function, use their NHS login, etc. as a single sign-on, which was seen as a benefit of the app. However, the adopters or the patients reported challenges related to initial registration, where some population group needed that support to sign on to use the app. There were also important cultural considerations, such as language barriers, with the app only being available in English. There are also certain functions, such as symptom check aspect, which was seen as less relevant to those with non-white skin color. More importantly, moving away from face-to-face interaction was a concern for some minority group, where having the trust and that relationship with the care providers was seen to be as quite important. So there were some limitations and barriers to how different groups could effectively engage with the app. Nevertheless, some patients did discuss that the information that they acquired from the app was useful to keep health services accountable. It also allowed them greater level of control over their health data, as well as to promote self-care. but the features that they could and could not access relied on external factors, such as the functions enabled by the GP practices, as well as their resource, knowledge, and skills of the GP team to support their patients. Therefore, the value proposition of the app itself relies on all these external services and external networks, as well as a local commissioning provides. So we do need to consider all of these factors when we look at the app itself. The complexity of how people can interact with the app and its different features, as well as the relationship between patient and provider, seem to interplay in how the app itself was being used. And this is a thread running through the qualitative aspect as well, while we see some of these inequalities also emerging in our quantitative findings. So to summarize our key results, what we found was the uptake of the app has been generally positive. In fact, 8.6% of all GP registered patients at May 2021 had signed on to use the app. However, there was a clear trend of inequality in terms of app use, where the different population groups interacted with the NHS app quite differently. So this highlights the importance of supporting vulnerable groups as well as people with important cultural concerns. However, with the app use being reliant on external services and factors, as well as patient and provider factors, we need to understand the support that is available to healthcare services. And there is also a need for efforts to encourage provider buy-in. Obviously, more work is needed to explore whether the app has any direct patient impact. This is something that we could not observe in our findings so far because we are using ecological data to observe some of these present level differences. But it is quite important to understand the health impact of the technology, which is key to understanding how such services can influence equity in health, as well as equality in healthcare access. Some of this is currently being explored in our ongoing work, and we will share the results in the near future as they become available. But for now, with this, I conclude the presentation. And I'd also like to acknowledge our wider project team and their contributions. And with that, I'd like to conclude the presentation there for today. So thank you so much for listening to my presentation, and please do feel free to reach out to me if you have any questions regarding the project or any of the findings that I've discussed today. Thank you so much.